Day 6. I am walking on a cold, little bit rainy New York night, headed to Gabe's for our last meal, our last watching of the Jordan documentary. Yeah, I'm tired. The end of the day today. Tomorrow's the last day, and then I fly back to San Francisco tomorrow night after leave at 6:30. So I'll work at the hospital all day and then fly back. And today I started to get sentimental. Started to realize that this that's not. Oh, that's not. It is not. Son of a bitch, that is not warm air that I'm feeling right now. I thought this would be like a nice little walk, and I'm not going down that street again. Good Lord. I started to take it in, for some of the last times. Because it's ending. Tomorrow's the last day, and then I'm out of here. It's been good. It's been good to serve. It's been good to, meet people and work with residents. I'm gonna miss them. Some goodbyes. It's been good serving on the front line with Gabe. Quite a tour of duty together. I think we've done a good job. But man, I'm tired. I'm exhausted. I need to sleep in. I'm gonna talk about a couple of medical things. I'm gonna talk about what happens when I get sleep deprived. I'll save that for later. It's a little embarrassing. We had a patient who was a psych patient yesterday who was put on our service. There were some concerns that it doesn't matter why they came on our service, but they were sent over from psych and didn't have corona symptoms, didn't have COVID on the x-ray or any of those findings. It was one of the rare patients that didn't have all of that. Didn't have any breathing problems, low oxygen, anything. The guy was just kind of a psych behavior guy who was really barely even there for any medical reasons. And we were trying to complete his evaluation and get him back to psych, where we felt his main problems were and needed to be cared for. And this is one of the things that's kind of characteristic of this COVID is how quickly people can get worse, get sick, decompensate. Some things gradually get worse. Heart failure, for example, or kidney failure, where you're retaining fluid or holding on to fluid. The fluid can build up over days, maybe weeks, and get worse. It's gradual. Anyway, there's a lot of diseases that can gradually get worse over days. But this guy, we had rounded on him in the morning, and he was fine. He was definitely fine. And then all of a sudden in the early afternoon, he decompensated. He got worse, and he, before he was kind of to be honest, he was call patients buttheads, but he was a butthead. He was difficult and combative and had a little attitude to him, and he was talking smack, and he was difficult. And I just about got ran over by a motorcycle. Anyway, in the early afternoon, the nurse alerted us that he all of a sudden got worse. And when this guy got worse, holy cow, did he get worse. Walked in there and he was breathing a very, very rapid rate. Sorry, this wind is probably terrible. I'm trying to maneuver around it, but all of a sudden, out of nowhere, his rate of breathing increases. He's sweating, like his face is just, little beads of sweat all over, and he's just incredibly struggling to breathe. Like you look at that from the door and you're like, oh, whoa, like what happened? Like all of a sudden he went from nothing, breathing comfortably normal, and then like wham. So we put him on oxygen, increased the oxygen, and had to put him on a form of ventilation called BiPAP, which is a machine that kind of pushes air in and out of the lungs and helps people to breathe. In this case, his was so severe that he escalated. A lot of times people will get worse, again, over hours or days, where you start them off on 2 liters of oxygen, and the next day they're worse, it's 5 liters, and the next day it's like 8 or 10, it just like kind of goes like that. But he went from not needing any to needing BiPAP, all of a sudden. And then they ended up transferring him to the ICU, and last night he got intubated. It was very memorable for me to see that and process how fast people can get sick. Whatever the cause might be, whether we're saying it's cytokine storm, after the virus is in your system, the reaction of your immune system, where certain inflammatory mediators, for whatever reason, overreact to the virus and cause problems like respiratory problems and failure. Maybe he had a clot in his lungs that had been thrown from a clot in his legs. I don't know what it was, but he ended up needing intubation and a form of life support for his respiratory failure. And it was just all of a sudden, damn, that happened. So we'll talk about the patients today. I've been talking about these guys all week. I got my folks, unfortunately, that are dying and are continuing to get worse. There's a lot of suffering. I don't know if I want to go into that. I'll talk about that maybe in a minute. We've got our folks that are getting better. Of these folks that are getting better, one thing I think that a lot of us are finding is, they get better 80% and then they get stuck. So, these guys were intubated. Their lungs got better. They needed less and less oxygen, so they were able to be extubated, get off the vent, and then, day to day they improved. Like I described before, they were on a face mask with a lot of oxygen, and then 10 liters, and then 5 liters. I'm in the subway, in case you didn't know. And I gotta put my mask on if I'm gonna get on the train, so I hope you can still hear me. Give me just a second and we will continue this conversation. I hope you can still hear me. Hang on just a second. So here you go. We're in the subway, and this is you're coming with me on the ride. We're going to Manhattan. It's a quick ride. So anyway, they get to this point where they're coming off of oxygen, and every day they get better, 10 liters to 8 liters to 4, and then they get stuck, needing 2 or 4 liters of oxygen. So if we take off the oxygen, their oxygen level drops below 90. They feel really short of breath. I can't send them home. They're not ready. If they didn't have it, they would get into trouble, get short of breath, and have problems, and end up coming back to the hospital. And so they're surviving, and they're going to be fine, but they can't go home. They're stuck. And we're finding that there's a handful of, a fair number of people that get better to a point and kind of get stuck. And the situation right now in New York is they've had so many people that need oxygen that they're out of oxygen tanks. In this system, people could go home if there was a tank of oxygen, but there isn't. And so they're stuck in the hospital for various reasons. Even though they're getting better and going in the right direction and going to be fine, they're still stuck there. Today I went to, is this even, I don't even know if this thing is worth, I don't even know if this is worth listening to. The audio is probably so bad. I just don't have a ton of time to finish this today, and I'm exhausted, so we're going to push through. Today I spent some time in the ICU. I went down from the floor, from the normal med-surg floor, down into the ICU and talked with one of the fellows down there about, what they were seeing and what's happened, and, it was really interesting. A lot of these guys here don't think that hydroxychloroquine, also known as Plaquenil, does much. Initially, they were treating with hydroxychloroquine and azithromycin, and it seemed like everybody was dying. And then they started throwing the kitchen sink, treating with everything, which included transfusing convalescent plasma for many people, using remdesivir, the antiviral that's in the news, and treating with steroids, which initially was thought to be a no-no. They would pulse solumedrol at a gram a day. And they would anticoagulate people. They would put them on a blood thinner like Lovenox to treat and prevent clots like pulmonary embolus. And they noticed that people did better. Staffing also had a lot to do with that. ICU nurses, instead of taking care of just 1 or 2 patients, were taking care of 7. Doctors were seeing 30 patients. I mean, that's crazy. That's why people died. So many reasons why people died. I'm going to have to put the mask back on again because we're out of the subway. I got to put the thing on. So I'm going to pick up right where I left off with that conversation on, from these front lines. What are they telling me? Why did so many people die? This study that showed there was over 80% mortality of ventilated patients in the ICU, and it's not like these patients came in and they were left on the street, or they got a room. The hospital expanded. They opened up new beds, new units. They did expand, but instead of seeing 15 patients, doctors saw double, which wasn't safe. And nurses were taking care of, instead of 1 or 2, 7 patients. Dialysis was a big thing that this particular ICU fellow that I talked to said was a problem for them. A lot of these patients develop kidney failure. This is kind of a common complication of COVID, and who knows exactly what the pathophysiology is with it. There's some kind of, maybe there's little clots that kind of get in and inhibit blood flow to the kidney, and the kidney suffers and fails temporarily, and so you have to put people on dialysis. And what he was saying initially was that there were so many of those patients that they didn't have enough dialysis nurses, dialysis machines. They didn't have enough people to do dialysis. And then the dialysis nurses got sick. And he said at one point they were only down to one nurse who could only do dialysis on one person, which takes about 2 hours to filter all the blood through the machine and remove fluid, toxins, etc. And so when you're only down to one nurse, that really limits your ability to, there's only so many people that person can see in a day. If it's 2 hours, that's only like 4 or 5 people, right? Depending on how long they're there. And so these are the ways that the system gets overwhelmed. So doctors are seeing too many patients, nurses are taking care of too many patients, care goes down. We have limitations as people. There's no criticism of the nurses and doctors that were in that situation. It's the system got overwhelmed. Dialysis nurses got sick. They weren't able to do, a form of life support that would have gotten some people through this, because the system was overwhelmed. Those are just some possible ways to explain why so many people died in that surge. And that's the whole flatten the curve. That's the whole sense of how the system gets overwhelmed and how it results in more people dying. There was a lot of talk about the fatality rate being around 1% with good care and going up to as much as 5 or 6% in these kind of overwhelmed surge conditions. It makes total sense to me now. If the system can't handle it, like, this is what happens. Taking care of too many people at once, doctors and nurses, running out of dialysis, the big focus was on running out of ventilators. It doesn't sound like that was an issue for them as much as the dialysis was. I found that interesting. So it was good to round with him. I think I already talked about, Gabe and I just had dinner with Gabe. It was taco night. We had some taco and burritos. It was bittersweet. It's been a good week with him. It's been great to be in that foxhole with a buddy. That added so much more to the experience for me. We watched episode 4 of the Michael Jordan documentary, Come Fly With Me. That's what he did in the 90s or 80s or whenever that was. The Last Dance, that's what it's called. And I found myself not wanting to leave, because that's I fly out tomorrow and I leave from the hospital to go to the airport, directly to the airport, and fly back to San Francisco. And, I'll miss Gabe, and I'll miss our routine and this whole thing, and this is kind of the sentimental side of me. It's been good service. It's been nice to be out here. I wouldn't call it a vacation, but it's been an adventure. And I feel lucky to have had the opportunity while a lot of people are quarantined at home, not able to do that. So just getting back, I'm just getting back from that and looking at this hotel room, which is a disaster with my clothes thrown all over it. Now I'm going to have to pack that and clean them up, and I think I'll do that in the morning, right? That's a good idea. Save that for the morning. But going through things with this ICU doctor, they talk about following a whole bunch of blood work every day on the patient. There's tons of different labs that we follow, but there's 2 basic ones that they really keep an eye on. One are called acute phase reactants, markers of inflammation or infection. And what they would observe is that when people, let's say people came in with coronavirus, they initially were doing better, and then sometimes they would just seemingly randomly get worse on day 5 or 7 or whatever. And that would correspond right along with these markers of inflammation shooting through the roof, going really high. The other ones are these markers of clot and clot breakdown. Things like D-dimer and fibrinogen and kind of observing how, like, especially the D-dimer, but, going up really high, or ferritin kind of being another acute phase reactant, another thing that kind of just basically indicates when somebody gets sick, and they really correspond well with how someone's doing with this COVID infection. They're kind of these markers, surrogate markers of infection. It was good to kind of review that with him. We talked a lot about certain folks not making it, certain folks being stuck on a breathing tube for 3 weeks. Some people who continue to go on and on and on the tube but don't have any real chance of meaningful recovery. So removing the breathing tube, unplugging them, as is crudely referred to. It's called terminal extubation, where you take the breathing tube out, and somebody's going to pass. Dealing with those intense issues in the ICU. He was talking about how they don't do CPR very often at all once somebody is intubated on maximum oxygen, getting all of the medications and life support medications. If their heart stops, then they're gone, because doing CPR and chest compressions and shocks is not going to bring them back. There's, they've died. And that makes sense to me. I agree with that. What else did he tell me in that conversation? That was a good conversation. And then I went later today, I went into the ER. Normally I do ER, and it's been good to be in the hospital taking care of admitted patients, because it's a different perspective on the disease, but I still wanted to know what they were doing in the ER for it. They did have a rapid test with a 15-minute turnaround time, but they were using that, and they were actually using that on people that they didn't think had COVID, so that they would isolate them, so that they would keep them away from people in the hospital that had it, because they didn't want those people to get it. A stroke patient, for example, who's going to be admitted, and they wanted to keep them away, to try to protect them from getting the infection in the hospital, because it's like almost everybody's got it. It's like if you don't have it when you come in, let's say you come in for a heart attack or a stroke or something else that's not coronavirus, you're coming into a hospital where 90% of the patients have it. There's a high likelihood you're going to be exposed, even if everybody does everything right. So that's how they were using that. Sounds like, these guys have seen a fair amount of young people that have had coronavirus. Some have ended up in the ER. But it's rare for young, healthy people to get admitted. Once you start getting some medical history, obesity, asthma, the risk goes up. But even then, it usually takes more years of poorly controlled chronic disease or increased age, and there is an element of bad luck when some people get stuff. This guy was wearing, this ER fellow, this ER fourth year resident was wearing this, it looked like I wouldn't say a Darth Vader mask, it looked like some kind of a space helmet. But the good thing about it was the face was all clear, so you could actually still see the guy's face, and you can be verbally, you can still have those facial expressions and communicate with that. I really liked that. That oddly seemed more human than a mask that covers your mouth to where you can't smile, You can't communicate in the millions of ways that our tiny little facial expressions do. So I thought that was cool. I mean, he's completely protected, and it's more human in that way. What else did the ER guy tell me? Honestly, the ER part is such an initial. I mean, the big, it's picking which tests, it's figuring out who needs to be admitted or not, and that mainly comes down to shortness of breath and really that oxygen saturation, that oxygen level. When they put the probe on your finger and measure the oxygen, that's what it's about. When people get sick, it's because they get short of breath. Breathing, feeling like you can't get a deep breath, walking or exertion, feeling short of breath. And if you're wondering, gosh, am I short of breath? Is this anxiety? Is it that? You can put the oxygen saturation on your finger and figure it out. That's a great test. You can go to the ER and get a chest x-ray and get blood work that looks for, this coronavirus. So it was good to stop by the ER and to see how they're doing things. And to be honest, like, ER medicine is such a different bird. When somebody's admitted to the hospital, it's far more complicated to manage all of these problems and get it taken care of to where they can go home. ER is really glorified triage. You're trying to figure out, does somebody need to stay in the hospital, or are they safe to go home? And there's such a vast range of people coming in with everything that it's really remarkable that we can handle as much as we do. But the other side of that is that you only see, it's like, if it's a football game, it's only the kickoff. It really is. And the internal medicine management of somebody in the hospital is far more complicated and challenging, I think, than what is done in the ER. Not to judge, nobody's better or worse. I do both, and I'm just, my perspective, I appreciated being on the wards this week and digging in and taking a little more time with these things. You don't have as much time in the ER. It's a lot faster. You don't have as much time to think through things and look at all of these tests. And God, it's 1 o'clock and I'm exhausted. You ever get that feeling where you're like so tired but you can't sleep, like so tired but still kind of wired and wide awake? I think I've just been running on too much adrenaline. Like, I need to get home and just sleep on Saturday. Take it easy. Yeah, so it's coming to a close. It's been a really good week, and I'm kind of sad to go. I'll probably do one of these tomorrow on riding back to the airport and try to pull my conclusions together. A lot of people are talking about, I've come to appreciate more that because the people who are dying from this are old and sick, I think we really have a responsibility, especially if we're doctors, to protect the weak, to advocate for the weak in these political conversations where everybody wants to open the economy back up. And I get it, like, economy affects everybody. And it isn't just money. It's not cynical money that the conversation is about. It really is about people's livelihoods. I think it should be done in a way, economy should be reopened in a way, to serve everybody and to keep us safe. And at the same time to protect the weak, which are the old and the sick. And if we don't do that, they will die. This really is less a disease of young, healthy people and more, the coronavirus taking the weak, taking the weakest in the herd. There's this, some people, that being the strong and the young and the powerful, like the idea of survival of the fittest. And I think we need to pause and really think about that. Has there ever been a time in your life when that wasn't you? When you weren't the fittest? When you were sick? When you were weak or hurt or young or a child? and remembering our own weakness. I think connecting with that grounds the value of protecting all of us, especially the weak. But I've just felt more convicted that that's something I'm gonna be clear about from here on out in these conversations about what the right thing is to do, going back to work and leaving the house and reopening the economy and all of that. It's a balance, but we got to protect the weak. We can't sacrifice people's lives for the economy. I think, there's always competitive things and the cost of doing things. And I'm not saying you shut everything down and keep people in their houses for a year. That's absurd. Economy does need to get going again, but you do it in a way that minimizes the loss of human life, not blows it off, not sacrifices it, not blatantly tries to lead some campaign that says, I'll take one for the economy. I'll give my life for the economy. That's nonsense and insane. That's completely insane. It needs to be framed that way, like these Bakersfield urgent care doctors that really are confused fools who ultimately are trying to keep their own businesses going, which in a way will ultimately lead to people dying. I'm not going to get into that now. Okay. It's time to go to bed. If you listened this far, thanks for listening. I'll do a couple more of these, at least one more, to wrap it up. It's been a good week. Take care of yourself. Stay safe. Stay sane. Do your part. Bye.